Hello and welcome to our lecture series for medical students rotating through the Pediatric Emergency Department. I'm Dr. Iman Lubani, one of the pediatric emergency physicians at London Health Sciences Centre in London, Ontario, Canada. So today we're going to be talking about febrile seizures in children. Our case to start off with, a 3-year-old boy, previously healthy. Yesterday, mom says he had a runny nose. Early this morning, while in bed with mom, she noticed that he was having shaking of both arms and both legs, and this shaking lasted about 2 minutes. He lost bladder control and was not conscious during that time, and EMS was called as a result. The seizure, or this shaking, stopped prior to EMS's arrival, so no medications were given. When EMS arrived, he was found awake but tired with a temperature of 39.5 degrees Celsius, tympanic. So the objectives today, we're going to define febrile seizures. We're going to understand the risk factors for febrile seizures. We're going to differentiate between simple and complex febrile seizures, and we're going to describe investigations in a child with febrile seizures. We're going to manage febrile seizures, and we're going to counsel regarding prognosis in a child with febrile seizures. So the definition of febrile seizures. By definition, a febrile seizure is a seizure episode in presence of a fever, where we define fever as greater than or equal to 38 degrees Celsius or 100.4 Fahrenheit. The fever is usually due to a viral infection, and most commonly this affects children between the ages of 6 months to 5 years. In fact, 2 to 5% of children in this age group experience febrile seizures. So that's a large number. This is something that we see often enough in the pediatric emergency department. This definition excludes patients with a previous history of afebrile seizures or epilepsy, with a history of CNS infections such as encephalitis or meningoencephalitis, or with metabolic or endocrine abnormalities. By definition, these patients, even if they have a fever and have seized with a fever, if they have these conditions, they cannot be called febrile seizures. Risk factors for febrile seizures. One of the largest risk factors for febrile seizures is neonatal discharge after 28 days of age. That means kids who were sick enough at birth to be admitted for over a month. Then, of course, developmental delay is a large risk factor for development of febrile seizures. A family history of febrile seizures is also quite a large risk factor, and in some cases this family history is not elicited at the time of presentation because the parents may not be aware of it. So often what will happen is these parents will go home after their child has had his or her febrile seizure, and they'll start asking grandparents, cousins, uncles, aunts, and they'll discover that there's a family history of febrile seizure. A family history of afebrile seizures or epilepsy is also a risk factor, maternal smoking, and then there are multiple other risk factors that are listed here. Those are the largest ones. So defining a simple febrile seizure versus a complex febrile seizure, the easiest way to do this is to look at what constitutes a simple febrile seizure. Anything that deviates from that is going to be a complex febrile seizure. So first of all, the type of seizure in a simple febrile seizure is a generalized tonic-clonic seizure. The frequency, no more than 1 seizure per 24 hours. The duration is less than 15 minutes. The majority of these children actually seize for less than 5 minutes, but the definition is less than 15. And neurologic exam, these are neurologically normal children who return to baseline within 1 to 2 hours post-ictally or after the seizure. Anything that deviates from that or does not meet those criteria is a complex febrile seizure. How do we investigate febrile seizures? Well, in terms of simple febrile seizures, it's easy. There are no investigations required. This is a clinical diagnosis. So we always do a complete history and physical to make sure we're not missing anything. And in terms of the physical exam, we're always looking for a possible source of the fever. So this most likely it's viral, but sometimes you'll find a bacterial source, such as, for example, otitis media, pneumonia, UTI. In complex febrile seizures, however, we want to make sure we're not missing any underlying abnormality, such as an endocrine abnormality or an underlying infection. So we do some blood work, such as what's listed above, as well as in some instances we think to do a urine tox screen, especially if the child is not returning to neurological baseline as expected. And in some cases, depending on how the child is looking clinically, we'll consider an LP or a CT head or an EEG. So how do we manage a febrile seizure? The most important component of management in febrile seizures is counseling the parents on what to do when their child is seizing. So I always tell the parents to take their child, place him or her on a safe surface on his or her side, remove all harmful objects from around the patient. So for example, if the patient is on the street when he or she seizes, remove them from the street, remove them from oncoming traffic, remove them from a bathtub, for example. If they're in a bathtub bathing, put them in a safe area and put them on their side. Time the seizure. Do not place any objects in the patient's mouth, because we still get parents coming in who've tried to put something in the patient's mouth so that the patient does not, quote unquote, swallow their tongue. This is something that's still out there. So we always emphasize that you should not be placing any objects in the patient's mouth. And then once you've started to time the seizure, if the seizure is lasting 5 minutes or longer, call EMS. If it resolves by 5 minutes, then you can take the patient to the emergency department by family car, where we'll evaluate them. We do not routinely recommend the use of benzodiazepines unless there's a history of prolonged febrile seizures, in which case we would give a prescription for sublingual Ativan, for example, rectal diazepam or sublingual Ativan, for example. We also do not routinely recommend anti-epileptic medications. They do have serious side effects in some cases. However, if you're getting recurrent or prolonged febrile seizures that are affecting the patient's quality of life, then the use of anti-epileptics can be discussed with pediatric neurology, and between the neurologist and the parent, a decision will be arrived at. Pediatric neurology referral and outpatient EEGs are not routinely done in these patients unless, again, there are atypical features to these febrile seizures, or you have recurrence of the febrile seizures to an extent that it's affecting the patient's quality of life. The prognosis for febrile seizures is excellent. They're common, they're generally very benign, and the majority resolve spontaneously and don't recur after the age of 6 years of age. However, in about a third of these patients, I warn parents that they may have more than one febrile seizure and that this can keep going on until the age of 6 years. And in about 2% of these cases, so 2 in 100 of these patients, you may have them develop epilepsy or unprovoked seizures. This, however, compares to a 1% risk in the general population, so it's not a huge difference in terms of absolute numbers. And I always remind parents that means that 98% of kids with febrile seizures will not develop epilepsy. So back to our case, this 3-year-old boy, Mohammed, previously healthy, yesterday had a runny nose, and early this morning was in bed with mom when she recognized what we're calling a generalized tonic-clonic seizure that lasted 2 minutes. He peed himself and EMS was called. The seizure stopped prior to EMS arriving. He was awake but tired, and he did have a fever. And now in our emergency department, he's back to his baseline. He's back to normal. So question 1, the vignette in our case describes A, simple febrile seizure, B, complex febrile seizure, C, unprovoked seizure, and D, type of dance. In this case, it's a generalized tonic-clonic seizure lasting less than 15 minutes. He's only had one ever, especially in the past 24 hours. And he is neurologically normal and has returned to his baseline. So that is, by definition, a simple febrile seizure. Question 2. The typical age range for febrile seizures is 2 months to 2 years old, 6 months to 10 years old, 6 months to 5 years old, or 1 month to 6 years old. And as you will remember from our slide on febrile seizures, the age range for febrile seizures is 6 months to 5 years old. So the correct answer here is C. Finally, our last question, question 3. You would counsel Mohammed's parents that he A. requires a CT scan to rule out intracranial bleed, B. should have blood work done to rule out infection or electrolyte abnormality, C. should be observed and if back to baseline discharged home with no investigations, or D. is likely to need medications to stop him from having further seizures. And as per our slide on management and counseling, we know that C is the correct answer. He should be observed and if back to baseline discharged home with no investigations. So that's it for our lecture on febrile seizures. I hope to see you guys in the emergency department. Best of luck to you all.